This conference will now be recorded.
Okay, this is John. This is AnCan's high-risk advanced metastatic prostate cancer support group for September 26, 2023. We're going to proceed with some new guys and with some old guys in a couple of minutes. First, I want to acknowledge the support of a number of sponsors that Rick has partnered with for us. None of these sponsors are requiring anything in return, such as pushing their products or anything. So I want you all to know that we're very much interested in the best thing for you, not the best thing of our sponsors, but we're very grateful for them for supporting us. Those are Pfizer Oncology and Myriad Genetics, Foundation Medicine, Telix and Bayer, Janssen, J&J Pharmaceuticals, and Myovant Sciences. And now it's time. We have 4 new people, and it takes a little while to introduce you new guys because we go through a little bit quickly through your history. We're going to try to spend at least 15 or 20 minutes on each of you, unless things are much simpler than they usually are. So we're going to ask one to wait until next week. But whoever that is, if you have any immediate questions, please feel free to contact me or Rick, and we'll try to make sure to get you whatever you need and to get by until next week. So, Mr. Marshall.
Yes, sir. Okay, results of the number 1 in the batter's box will be Tim.
Oh.
Number 2 in the batter box will be Colonel Boykin or Colonel Jordan. And the last one, and with the cleanup, will be Greg S.
Okay. Okay, Gary, are we okay? Gary Zoliner, are we okay to?
Sure, thank you.
Okay, sorry about that.
Oh, no, I totally understand. I do want to thank Mr. Marshall. He is the person who introduced me to the organization, and very grateful to be here tonight.
Very good. Then call him if there's any questions in the meantime. So, Tim, let me find your. Oh, there you are. Okay, very good. Okay, so we have a few questions.
Okay.
We start by asking you how old you are.
I'm 78 as of Friday, and I just got my DMV renewed. That's a major accomplishment.
Okay, good. Did they make you take an eye test or anything?
Eye test and a written test at that age.
They did. Oh boy.
Yeah.
Not looking forward to that. Okay, and where do you live?
I live in San Jose, California.
I've just lost your picture. What the heck? Oh, there you are. Okay, San Jose?
Mm-hmm.
Okay. And tell us about when you got diagnosed.
Okay, well, first, I just want to acknowledge Mark Valens for referring me to this. As of this morning, I'd never heard of this. And we met this morning through my brother, and I'm very appreciative of that introduction. I was diagnosed in January of 2022, and 2022. In April of 2023, my diagnosis shifted from a treatment for remission to recognizing that I was managing metastatic castrate-resistant prostate cancer.
You mean of April of what? 2023?
Right, 6 months ago.
Okay, so you got a little over a year. So when you first got diagnosed, I suppose that was probably by a biopsy, right?
Yes.
And that was benign enough for you to be on just watchful waiting or something like that at that
No,
time?
it was malignant. It was removed, and
Oh,
I was placed on chemo drugs and went through 10 weeks of radiation treatment, and then subsequently started a 2 year treatment program, which hopefully would lead to remission.
okay. But instead of remission, what happened is that a year later,
A year later, it was determined that my cancer was very aggressive, was spreading quickly, and that I'm terminal, and my circumstances to manage my cancer.
so what's your current updated diagnosis now? What's your Gleason score from your surgery?
I have no idea what my Gleason score is. Um,
Okay.
my PSA is north of 40, and my testosterone is still less than 0.
Okay, that's from you're on some sort of androgen deprivation therapy, right? Lupron or something like that?
I was put on chemotherapy, 10, 10 treatments of infusion treatments, separated by
And that,
3 weeks. So 30 weeks of treatment.
do you remember the name of your chemotherapy, Tim?
Excuse me?
Do you remember the
Uh,
name of your chemo?
it starts with a D. I can go get it.
Docetaxel. Okay,
Docetaxel,
docetaxel.
yeah.
Okay.
And my treatment was discontinued less than a month ago because I was on my 6th treatment, and it was obvious that my PSA was climbing, continuing to climb, and there had been no sign that the treatment was actually effective. So, so I am
I got a little
right.
confused for a second there. Was your chemotherapy after your diagnosis and your prostatectomy, or not until your recurrence in April of 2023?
I went on chemo drugs as part of my original treatment plan,
Original treatment plan. Okay.
but then
Docetaxel plus.
subsequently that shifted to an infusion program of 30 weeks, 10 treatments over 30 weeks, separated by 3 weeks.
Of docetaxel again?
Correct.
Okay. Okay. And what was
So
your anti?
was
What
that,
was your
excuse me, John. So that was at full dose every 3 weeks, 10
Correct.
treatments. Right. Got it.
Right.
Sorry, John.
So essentially, I would have 1 week of recovering from the treatment, and ideally, ideally 2 weeks of being normal, or 10 days of being normal, or
has your is has your prostate cancer gone outside the prostate somewhere?
yes, I have bone cancer, I have um, lymph node cancer, and there's evidence that um, my lungs may be involved. I'm slated for another um, PET scan to take a look at my lung circumstance.
When are you going to have that?
The end of October, 26th of October. Currently, I'm just weaning off of my last steroid from this regimen of infusion treatments, as they've taken me off that program. Last week, I was interviewed for nuclear medicine, isotope program, isotope radiation program, but was not found qualified because my cancers do not have the um, do not have the markers that are needed to be a part of that program. So this week I'll be discussing with my doctor what treatment regimen he is looking as a follow-on.
Who's that?
Dr. Sumit Shah at Stanford. I've been at Stanford throughout this.
Okay. And when you gonna be talking to him again?
On Thursday.
Okay. So you have you probably had some genetic testing, have you?
I don't know if I have or not.
Okay.
I'd have to ask.
Did you ever have one where they took a cheek swab,
No.
swabbed your cheek and sent it off? No. Okay. It could have been a blood test, or could have been a test on your prostatectomy sample, or anything like that. Do you have any family members with cancer?
Not currently. I've had a niece. I've had grandparents that had cancer, but no, relatively healthy family. I'm a
Okay.
Vietnam vet,
Uh-huh.
and there appears to be some evidence to this form of cancer being associated with age, a residual disease from ischemia. I have ischemia heart disease from Vietnam,
Oh,
and so there's some evidence that it could be derivative from that exposure years ago.
And when you say this form of cancer, do you happen to know what the pathologist called the form of cancer that you have when they looked at your prostatectomy?
I don't know, but to me, it's deadly. So I
Okay.
don't know. I don't know what they call it.
Okay. So, so your situation is in flux right now. You haven't responded. You responded for a year and a few months,
But no,
and
actually, I didn't respond. That's why they, at the end of the first year, they had seen an increasing lack of response. So they, I went through other scans and tests apparently, and that's when they determined that my cancer was this aggressive form of cancer.
okay, and okay, so never really responded that well.
Right. I just
Did your
never.
PSA ever go down to zero?
No, no. The
Never did
closest
it.
I got to was like 2.4, and then it reversed itself. And by the end of the first year, it was already at 5 and starting to climb. And then it's
Could you
climbed
tell me what that low number was again? 2.4?
2.4.
2.4, okay. And now you're in the now you're 40 or something like
I'm
that,
north of
right?
40. I haven't had a test in 2 weeks. And in the 2 weeks between 40 and 29, I went up, 11 or 12 points. So I expect that I'll be climbing the next time I'm tested.
Okay. Um, all right, very good. And you like Dr. Shah, okay? You're
I,
comfortable and
I'm, I've been a cancer client for over 20 years. I've always had great care in the heart department, and the oncology department has just been superb.
you had another cancer before this?
Not cancer, I have my heart disease.
Oh, heart. Oh, I thought you said you were a cancer client for 20
No,
years.
just a Stanford client. Stanford
Oh, at
client.
Stanford. Oh, I understand. I understand. Okay. Okay, very good.
So, what were the original when you first got diagnosed? Um, they did. You had said they removed it, but did you have something removed?
Yes, I had a lesion removed between my prostate and my bladder. And the lesion was growing and pressing against the bladder, and they were concerned that it would ruptured the bladder. So at the time, at the
Okay.
time they took it out, regardless of whether it was benign or malignant, and it turned out to be malignant.
Okay. And did they not? Did they give you a reading on the Gleason score of that lesion, or
No, I've
not? They
never
did
had.
not.
I mean, I can ask them on Thursday, but I've never
Yeah.
discussed the
I
Gleason.
mean, it would be helpful. It's not essential. I think the key question that we would like to know is have you ever been sequenced? Have you ever had somatic sequencing?
I don't even know what that is.
Okay. Have they ever sent that lesion off to be for DNA analysis?
I can ask that. I don't know the answer to that.
Well, you don't want to be asking that. You want to be telling them that's what you want. And the reason why is because there are treatments today that are indicated according to what the results are. So
Mhm.
you have certain if you have certain mutations or certain characteristics, it may indicate a treatment for you.
Okay,
Um,
I'll be glad to bring that up.
from what you're saying, it sounds like you are not PSMA avid. They gave you a PSMA scan, but nothing showed.
Mhm.
Does that sound right?
Correct.
So if you're not PSMA avid, it's possible that you may have other features that might make you eligible for, say, immunotherapy or certain types of immunotherapy, but we don't know yet. So it's really essential. I mean, it's not just essential; it's required by the NCCN and other agencies that you should have been sequenced already.
Well, I may
Now,
very well have been, but
you may have been
I just
if
didn't
you
focus on that conversation then.
right.
If he had
So
that with.
So if you have not been, it should be done. If you have been, see if you can find out, get a copy of that report and share it with us, because that's going to dictate what to do next. What other than the Lupron? I mean, they put you on an LHRH to begin with. It might have been Firmagon or Lupron
That
or
was Firmagon
Orbital.
and Lupron I've been on since the beginning.
Right. So Firmagon, Lupron, and what other drugs? What other secondary drugs did they put you on before the chemo or
Nothing.
with the chemo?
So two.
Nothing.
Yeah.
See, again, I mean, for somebody like yourself, what seems to be best indicated, since you were what's called de novo metastatic, is what's called triplet therapy. So what's indicated is an LHRH drug like Firmagon or Lupron, a secondary drug like abiraterone or enzalutamide or darolutamide or apalutamide, and chemotherapy. But along the way, the second line antiandrogen didn't get invoked, and the research shows that, in fact, that's the optimal treatment. Um, the medical oncologist that you have, you said his name is Shah. Is that, how do you spell that?
SHAH.
SHAH. And is he a genitourinary medical oncologist? Does he specialize in prostate cancer? Is it Neil Shah? Is that his first? Is his
No,
first name Neil?
Sumit Shah. SUMIT.
Oh yeah, you said that. And does he specialize in prostate cancer?
Uh, yes. I mean, I'll
Okay.
clarify that with him, but it's been.
Okay, we can certainly take a look. But it surprises me at an institution like Stanford, if he is a GU medical oncologist, that he's not using all three of those treatments up front. But there may be reasons, and it may be even something having to do with your heart, could be. Abiraterone might not be a great drug for you.
I also have kidney issues, so they've had to consider that in my treatment.
Okay. So I'm sorry, Dr. John. I just wanted to clarify some things, which I think now that we know that a lesion was removed, have you ever discussed treating your primary with radiation?
My primary, are you talking about my prostate?
Yeah.
He had that, I
I've
think.
had 10 weeks of radiation treatment.
Oh, you did have 10 weeks of, you had radiation treatment up front.
Yes.
Okay.
Yeah. So what is the sequencing, and what was the other item? Mark mentioned it this morning that I should ask about. That what was that marker, Mark, that you?
The Gleason score.
Gleason.
Yeah, I think it would help us if you decide you want to come back. It might help us if you could find out your
No, I'll be
original.
glad to come back. I'm
You
thrilled.
probably got a Gleason score with your biopsy, and you've probably got another one with your radical prostatectomy.
Yeah, well, I'll be thrilled to come back. I've been looking for a group like this, and Mark, it was like manna from heaven this morning. So I'm very appreciative of the questions,
And what do you like?
I'm very engaged in my treatment program. So you'll be teaching me a lot of things, and I'm grateful for that.
And what else can we do
I
for
do
you?
have 3 questions.
Yes,
Because I understood that you would answer simple questions.
we
for
will
those.
answer simple questions, even
Okay.
complicated ones.
Okay. Maybe I only have one question, but I've had 3 major side effects from the chemotherapy. I didn't have any side effects the first year when I was in the original program, but since we started the total infusion program, I lost my hair, and I've been assured that my hair will come back, even if it comes back curly and red, which I would be totally fine with.
Yes.
I have lost my fingernails, which is gross to grandkids. But the issue that I live with, I'm a hiker and a walker, and I walked 10 miles up until the 10th of June every day.
Oh,
So I was well into my 3rd month of treatment when this hit, and that's neuropathy. Both my fingertips and my feet are driving me wild. And
Right.
I'm now off the chemo, and I was just wondering if anyone has had a similar experience, and how long does it take for the neuropathy to wear off? So that's my question.
Peter Kafka, have a shot.
Peter's still here? I don't see his picture.
He came in. Is he not? Is he not with us? Okay.
He dropped off about 7-8 minutes ago.
Okay. Okay. Go ahead, John. I think this is. Do you have neuropathy? I'm not sure.
I have minor neuropathy, but if there's somebody here that's really struggled with it, I would like them to speak. It does wear off quite slowly. I think we've had a number of people that have had neuropathy, and
Okay.
exercise is profoundly important to your quality of life from here on. And so
Yes.
we really want you to stay out there hiking. So, people have tried various things for their neuropathy, sometimes vitamins, sometimes anti-seizure medications. There's no miracle cures, but if it's due to your docetaxel or some drug that you're going to stop, and not due to something like poor arterial circulation or nerve damage, then there might be some easing up of it as the stuff wears off. But it takes quite a bit of time for nerves to heal.
Okay. Well, I've been off doxycycline for about a month. So, in other words, what you're saying is patience. It will wear off, but it'll take some.
Jim Barnes. Go. I know you have experience and you have your hand up. Go ahead.
Yeah, I had my my sixth docetaxel treatment last November, and I had a number of side effects, including hair loss, which is all come back, and I refuse to get it cut now. So, and then I lost my fingernails and my toenails as well. They've all come back pretty nicely. So but I'm 7 8 months out of it now, and I do have neuropathy in my feet, and sometimes it's worse than others, but it feels like it's slowly but surely getting better.
Okay. But you're 7 months into it, so I thank you for that, because that frames my thinking and slows me down to realize it's going to be a long haul.
Yeah,
Yeah.
that's what I tell everybody. The thing they don't tell you about chemotherapy is it takes you about six months to recover fully.
Yeah. Yeah.
But I'm getting out there and playing golf like 3 times a week. A couple days I've been out playing 27 holes and that sort of
Okay.
thing. So I'm back to normal and feeling strong and feeling good actually.
That's fabulous to hear. So I appreciate it, and I to all of
So
you, I thank you for the well.
here's a tip for you, Tim. Are you taking B6? Are you taking vitamin B6?
I know. I no.
Okay, so you should mention this to Dr. Shah. But and I know this, I got this from Peter Kafka, who was with us and then he had to drop off. He may be back because he suffered from neuropathy from chemotherapy significantly. I didn't have chemotherapy. I had a fair amount of Lupron, and I have neuropathy from that, which can happen.
Okay.
I take, I think it's 100 milligrams. I think they're hundreds of B6. I take one a day. You can take a lot more. And
Okay.
I found that it helped me a lot with my neuropathy, a huge amount. But it takes a while to build up. So you're not going to take one and then the next day you're going to be fine. It can take 2, 3, 4 weeks to build up. But it is known to help. It's also known to cause neuropathy if taken in too large doses. But we always say, let your doc know, let Shah know. Shah is a GU med onc, and let him know. And you may find that helps. But the fact that you're only a month off the end of your docetaxel is it just takes time. And John, I know you've got 2 or 3 people that want to say something.
I do. I have 3 people with comments, and then we'll move on. Cliff.
Hi. I just want a clarification. Tim, did you have a radical prostatectomy or not?
I don't even know what that is.
Okay. Then you just had a biopsy and they took out a lymph node, right?
No, they took out a lesion off of my prostate.
Okay, a lesion. Okay. I just wonder. I heard 2 different things there. I know about, but I did not hear the radical prostatectomy, and I think Dr. John said you may have had that, and I wasn't sure.
Right.
That may be from jumping to conclusions on my part. That's a very good point.
Yeah.
Did they take your entire prostate out?
No, they didn't take any of my prostate out. They took a lesion.
Oh, thank you, Cliff.
Yeah. So, colleagues, I want to thank you so much for this. Unfortunately, my daughter is arriving, and so I would have to conclude my conversation with you right now. She's.
Excuse me,
2
Tim.
things.
I'll certainly be back. I'll certainly be back next week.
2 things quickly. I'm going where you're going, Jim.
Okay, thank you.
One, we need. Do we have your email address?
No, but Mark does, but I'll send it. I'll register properly.
Okay. We have on Thursday night, we have a veterans group where we discuss veterans benefits. We don't discuss treatment, we discuss veterans benefits. It would probably be very wise for you to join that group.
Yes.
It's at 5 o'clock in this same room on Thursday. And there, people like Jim Marshall and others in this group who are veterans, who are very, very familiar with the system, with the VA system, those who are dual enrolled. They'll take you through what benefits you might be able to get to if you haven't already gotten them. So we strongly, strongly suggest, if you want to put in the chat window your email address, you can send it just to me, put it in for everyone. We'll make sure you get reminders for that meeting.
Okay. Thank you.
Did I cover what you wanted, Jim?
Yes, sir. And Tim, you are entitled to big time money.
All right.
Trust me.
I'll be there on Thursday and I'll be looking for you, Jim.
Thank you.
Nice to meet you, Tim.
Thank you, everybody. And again, thank you, Mark. I'll see you next week.
Okay.
I know.
Appreciate it.
Boykin Jordan, is Boykin the first name and Jordan the last name?
That is correct. Boykin is the first name. Jordan's the last name.
Okay, let's introduce you to the group. How old are you, Boykin?
Okay, I'm 61, but I want to send a shout out to Jim Marshall.
Yeah.
Right up front, because I met him in another support group, and he's been like a brother, pushing me to do all the right things and forcing me to think really hard. And so, Jim, I appreciate it. Okay, I'm sorry. I'm 61.
Where do you live?
In Springfield, Virginia, Fairfax County, right outside of Washington, D.C.
Okay, my time zone. I'm in Connecticut.
Yes.
What year were you diagnosed?
Last month in August.
Last month. Oh, jeez. Okay, Brandon.
Okay.
That's good. Welcome to the group. Welcome to the group. What did they tell you about your diagnosis and your treatment plan?
So I know my Gleason score is a 9.
That's a 4 + 5 for anyone.
Yes, I have a couple 4 + 5s. My PSA on August the 30th was 45.6. And they talked to me. I went through the what they call a multidisciplinary clinic, and so they talked to us about all the different treatment options at a high level. But I had a kidney transplant, and that sort of in 2018, and so that sort of drove the treatment options for me a little bit.
Yeah.
And so they had me scheduled for the robot assisted one. I can't pronounce the word, but you guys know what I'm talking about, where they remove the prostate.
Prostatectomy.
I'm sure I'll learn it eventually, but
Prostatectomy. That's what I thought Tim had until I got straightened out by Cliff. Yes.
Right,
Okay.
right. And
so they think that that's the best option, given that you've had a renal transplant.
Yes.
And okay. And
yes.
You had seminal vesicle invasion, as I understand it.
Yes, I think so.
But you didn't have any lymph nodes that had cancer in them.
No
right?
lymph nodes, and it says. I mean, I don't understand half this stuff, but it said some of them did have like the seminal evidence of seminal invasion. I think that's the terminology.
Yes. Okay. Okay.
It says peral neural invasion identified, and it keeps saying cribiform. Okay, thank you. Pattern identified in almost all of them.
Okay. And other than that, it called you an adenocarcinoma, right?
Say that again. I'm sorry, Dr. John.
You called it an adenocarcinoma on your report when they did your biopsy.
Yes, that's what they called it.
Okay. And Okay, so PSA now 45.6. Has there been time for any other tests such as scans or genetic tests yet, or is it too soon?
Okay. I took a genetic test last week. I can't remember which day, but I took a genetic test last week. It was the blood one. I think that's the
Yep,
germline.
yep.
And they told me it would take a couple, 2 or 3 months to get the results back.
Okay. Do you know what company they sent that to?
No, I didn't ask. I just know it's at Walter Reed.
Okay. Do
Right,
you
but I
have
didn't ask. I
any
can find out.
do you have any family members with cancer?
No. All of my most of most of the men in my family basically died except for my father. As far as like my uncles, that would be by birth, and my grandfathers would had passed away when I was a little boy,
Oh, but not from cancer, huh?
but not from cancer.
Not from
But to
cancer.
be
Okay.
honest, given their state and the medical conditions and history back then, I wouldn't know.
Hmm.
They just passed. Is all I ever heard.
Now, are you is it considered to be contraindicated for you to have any radiation treatment?
Well, that's what the radiation oncologist was worried about when I talked to him. Is that I couldn't do I is that they couldn't get the external beam to work.
Yeah.
The one and had concerns about that, how that would impact the kidney. There's another one that they could do like a photon, and they told me about that one as well. But
Proton. Hmm.
yes, and I think that's and the way I understand it is the proton is they can be a little bit more focused, but they wanted to wait and do that one as secondary if needed.
Okay. And no scans of any sort yet? Like
I had a
bone
PET.
scans, CAT.
No, not specific for this. I had a PSMA PET scan, and of course I had a biopsy.
What did the PSMA PET scan say?
The PSMA PET scan, it essentially says um, the it says the psychological distribution of tracers seen in the salivary and lacrimal glands, blood pool, liver, spleen, pancreas, ganglia, bone marrow, bowel, kidneys, and urinary tract. Then it said, as far as the prostate, asymmetric. Am I going too fast?
No, I got it.
Okay. Asymmetric left gland uptake extending from the base to the apex. Then it's got in parentheses something called SUV max 19.27 axial 260/335. And then it says correlating to no left peripheral zone
All right.
PI-RADS5
So,
lesion.
hold on a second,
Okay.
Colonel.
Basically, what this boils. Okay, I'm gonna get
It's
to
all in
just
the
as.
gland.
Yeah, that's just what I was gonna say. It's
Right,
all in
it's
the
all in the
gland.
gland. Did the PSMA PET indicate there was any cancer outside of the prostate gland?
No, it was all in the prostate gland.
Great,
Hmm.
great.
Hmm.
And did they not do a bone scan and a CT scan as well as the PSMA scan? Because normally that's what they'll do, especially if you're 4+5.
Okay,
It's
so
required.
it's included with the PET scan, I think, even though I wasn't thinking about it because I'm looking at it now. It says significantly low dose CT findings. Is that what you're?
Yep. Yep.
Okay,
Yeah,
because they did
yeah.
like my
Go ahead.
whole body,
Yeah.
but they didn't do a bone scan. They didn't do a bone scan. I know
Okay.
that 'cause somebody else asked me about that.
Okay.
But
So
let's assume there was nothing.
yeah. Yeah.
Right.
So the key here is really the following, Boykin, and I think we sort of conveyed this back to you through Captain Jim,
Mhm.
is that the likelihood is that with a diagnosis like this, you're probably facing radiation and hormone therapy anyway.
Yes. Hmm.
And doing the radical prostatectomy is not a bad thing. It certainly is an advantage in terms of survival by probably 2 or 3%. But the fact is that you're going to have to face radiation and hormone therapy in the long run anyway. So you have to make, and you're young, so because you're 61, that's why they like to do the radical prostatectomy. But you're going to have to face the decision as to whether you want to add a whole additional slew of side effects for the radical prostatectomy, or if you are a candidate anyway, notwithstanding the kidney issue, for radiation, whether you want to limit it just to the radiation and the hormone therapy and not have to deal with the additional side effects of the radical prostatectomy. That's the conversation that your medical team at Walter Reed should be having with you.
Hmm.
And the other issue, I think, which you have to decide. So, I mean, given that I expect you have TRICARE, correct?
Yes.
So, given that you have TRICARE, where's the best place for you to be treated? You know, should you be at Walter Reed, or with a diagnosis like this, would you be better off going to say Sibley, which is now a Johns Hopkins hospital, or going up to Baltimore and going to Hopkins? And whilst, the care at Reed is okay, and we have other people on this call who have experienced care at Walter Reed, um, it's not great when it comes to more advanced and more complicated cancer. That they're just not equipped. For example, they don't have a genitourinary medical oncologist on staff. So those are the sorts of things that we can talk to you here about, and the decisions you have to make, whether you want to dive into this at Hopkins, at Walter Reed, or whether you might be better off. And I see that we've got two vets with their hands up. Cliff Collins has faced this decision before. Cliff, I think, shouldn't we be addressing you as Colonel as well?
No, I would prefer a doctor is a better term for me.
Okay.
PhD.
Okay.
Higher and deeper.
Higher and deeper, but you have a rank. I know you have a rank, so don't try and hide it.
I'll go with PhD. I don't want to go there. Anyway,
Okay.
what my
Yeah, I
question?
don't care about mines no more.
Okay, my question is, I spent more time doing my PhD work than I did in the Air Force. So, and I was also an educator in the Air Force. So, none of that. My question is, who is your doctor at Walter Reed?
Dr. Chestnut?
Yes, Dr. Chestnut. Okay,
Yep.
all right. I took Rick's advice, and I did go to Sibley, and I did meet with a GU oncologist, and I like the program there. I think you should consider it. At least go there for a second opinion. That's all I
Okay.
really have to say about it. I just think you should go there as a second opinion and see what they have to say.
Okay.
Okay.
Thank you, Cliff. How about you, Frank? What do you got? Still
You're
muted, Frank.
muted, Frank. Unmute.
There we go. Okay, just as a quick point of reference, I just had a biopsy and a genetic testing with Foundation One at the OSU James in Columbus, Ohio, and it took 3 days to get my results back. So anybody that tells you it takes weeks, that's not so.
Okay. Thank you.
Okay. Yeah. And all of these, both these gents happen to be military. Both of them have used both the VA system and the private system. And Jim Marshall has his hand up and he wants to say something. This is the Jim Marshall show tonight. Go ahead, Jim Marshall.
Cliff, okay, is there a person there that you think is good, let's see, at Sibley? Because just to blindly go in there is, hard.
Yes, there is. Her name escapes me now. It's a female. She's done a lot of research. She speaks at a lot of the conferences. I'm sure somebody will come up with her name.
Yeah,
But
I'll give it to you.
I'll put it in the chat if I can remember it.
Step up,
I'll
Gary
find it.
Peters.
I'm sorry?
Hello, Gary.
I
Gary
think
Peters,
Cliff is referring to Channing Paller.
Channing Paller. That's her. Channing Paller.
Right.
Yes.
Her
That's who
last
I met
name.
with. I really like her, and she's very good.
Right. So I just want to say one thing about Channing Paller, and she is great, and she might be a good starting point, but she's a medical oncologist. And what you are really, and she might be an excellent person in your particular case, given your other medical conditions, and the fact that you're not sure which way to go and whether to do the surgery or not. Normally, for somebody like yourself, we would say start with a urologist, a surgeon, or a radiation oncologist. But I think it's probably not a bad idea to start with Channing Paller because she's going to be able to help you with this decision about whether to go the extra mile and do the surgery or not do the surgery. She knows us. She knows AnCan. She's done webinars for us. She's smart. She's good. She knows Cliff. She knows other people from our group. So she might be a good person to start with. And then I think you've got to also make the decision, where do you want to go through this treatment? Do you want to go through it at Walter Reed, or do you want to go through it in the Johns Hopkins system?
Gotcha.
Joel, did you want to say something?
Yeah, definitely. I would choose Walter Reed. I've had several men go to Walter Reed, and they all saw Chestnut, and he's a urologist, and they've all been managed at Walter Reed by a nurse practitioner. And so I recommend John Hopkins, obviously.
Right. That's the word. Since we're talking rank, Colonel, that's the word from the general. Okay.
Got it. Heard him.
Get the second opinion though.
Gotcha.
As well. I really think so. In your case, this decision about the prostatectomy is a very tricky one. Generally speaking, when a new person gets a prostatectomy, they consider it an attempt at cure. That's not the case, I don't believe. I think the chances of cure from the prostatectomy are very, very low. But even though it might not be able to cure you, like Rick said, it might be associated with taking the bulk of the tumor out of your body, almost all of it, and might be associated with a longer span of working with this in the future. it's a tricky decision. And don't
Yeah,
minimize the adverse effects of prostatectomy either. They're not trivial. And
right,
we'll be with you all along the way if you
right.
decide to stay with us, because we've gone through similar decisions. I know when I was in your spot, I was a nervous wreck trying to decide whether to have that prostatectomy or not. And we want you to make sure to take a very active part in the decision yourself,
Right.
so that you don't suffer from, oh, I should have done the opposite later on, you know?
Gotcha.
Yeah,
But
I faced this decision myself at age 56, and I wasn't fortunately I didn't have seminal vesical invasion, and I was a 4+4 rather than a 4+5. And I spent a lot of time trying to figure out, well, and I wanted to do the radical prostatectomy, and I tried to figure out, does that really make a difference? Should I do it? Because I knew in my case, I only had a 30% chance that I wouldn't have to do hormone therapy and radiation. In your case, it's going to be smaller than 30% because you have seminal vesical invasion
way
and you're
smaller.
4+5, even though you're a little bit older. So, my guess without running the nomogram is, and I think, and Jim Marshall can help you run that nomogram if you haven't done it already. But my guess is you're going to be around the 15% level. That's just a guess.
I bet
So
even lower.
it could be lower. So I went and asked probably one of the best urologists in the world, urologic oncologists, and certainly in the country, Dr. Peter Carroll at UCSF. And he said that from his experience, maybe a 3 to 4% difference from adding that. It could make a 3 to 4% difference, but we don't know. And the work's never really been done as to, well, what difference does a radical prostatectomy make if you're going to do hormone therapy and radiation? I mean, you're probably looking at somewhere between 18 to 28 months of hormone therapy anyway.
Right.
And so, that's the decision. Now, you could roll the dice and you could see if you come out clean, but you're rolling the dice with it probably stacked at least 80% against you. So you have to decide if you want to do that.
Gotcha. Mhm.
So for Boykin, Matt Krieger's asking, for Boykin, what makes a prostatectomy less likely for cure? Is it the evidence of seminal vesical invasion? Yes. It's the fact that he's 4+5, Matt, and
Ah,
that he has seminal vesical invasion, so he's already considered to be T3B. So, as a T3B, is it T3B or it might even be T3C? I can't remember. Definitely T3B. But it's the fact that he's T3B already, and we know that says chances are this is already somewhere. It's locally spread. In my case, it had spread to the prostate bed, so it was
okay.
out the capsule.
Okay.
Okay.
I think
Yes.
one of the critical things too is going to be how much radiation, how aggressive can the radiation oncologist be? If the radiation oncologist is unable to give you the treatment that they really want to because of your transplantation status, then that makes you have to be
Right.
more aggressive on the other aspects of treatment.
Right.
Well, that's what Dr. Greer, the radiation oncologist I talked to, that's what he was saying, is that they'd have to somehow cut back or that they'd have to look at something else, a different type of radiation.
Well,
Yeah.
Right.
there's a couple of things there. I mean, one is that you can, there's certain radiation that they can do to the prostate that they can keep it pretty limited, namely with either brachytherapy, high dose brachytherapy, or SBRT. I think the bigger issue comes when they're talking about how do they radiate your pelvic girdle, which is what they would probably need to do. The doctor I would speak to in your area, the radiation oncologist that I would seek for a second opinion would be Sean Collins in at Georgetown.
Yeah.
He's
Right.
really good. And have you heard his name before?
Yes.
Yeah.
Yes. Yes.
Yeah. So you know, and so Matt Krieger, were you faced with, now I recall who you are, Matt. Were you faced with this decision as to whether to do a prostatectomy or not?
Yeah, a pretty similar situation, right? And interestingly, my nomogram had even less likelihood of cure with a prostatectomy than Boykin's, even though there wasn't evidence of the vesical invasion. So a similar situation, and I agree with folks that the details around the radiation with the the transplant is pretty important here. It's but you have a lot of really good information you're going with,
Right.
including PSMA PET scan, which is great to have in your situation. And so you have a lot of really good information and obviously advice from folks here. So
Right.
Let's let Jim get the last word in, and then I'll go on to the Browns.
Okay, on the last word, concerning once you are treated down the road, and with Walter Reed isn't strong on the ADT. I have been in the support group for them for about close to 3 years, and I've only had 2 or 3 guys on strictly ADT, none on a second level anti-androgen. So as I said, they're not very strong on that at all. So just be aware of it, and I would say educate yourself. And if you happen to stay there and you stay with us, you will learn all about a second level anti-androgen.
Yep.
I've been on one for 5 years and a treatment holiday now for 13 months.
Okay. No, thank you, because I've heard of that before. So, but I didn't understand it. To be, it's kind of all going like. Choo-choo.
Yeah, yeah. Well, it's nice to
Take
have
time.
you, Boykin. Welcome to group, and I hope we see you again.
Absolutely, you'll see me again.
Gary, I already know some things about you, but can you unmute yourself? And if you have a camera, turn it on, and I'll ask you some of the same questions.
I think isn't this Greg?
Yeah, you're
You
talking
said
to
Gary.
Greg? Yeah.
Uh,
Greg.
Gary wasn't number 3. It was Greg.
Right.
I'm sorry. Okay, where's Greg on here? Let's see.
If you speak,
Oh,
if
there you
Greg,
are. Thank you. I see you. Sorry. Okay, I don't know anything about you, Greg. How old are you?
Okay, I'm 69. I was, and Neil's my brother, and I was diagnosed at 64, been 5.5 years. At my diagnosis, I was already metastatic. I was Gleason 9 in my biopsy. 5 out of the 10 cores, all on one side. I can't remember which side were all full of cancer. I immediately I saw a urologist. He stuck his finger up my butt, and he went, "Oh," just like that. And I went, "Okay, we're in trouble now." And and he immediately,
Don't they teach doctors never to say "oh shit" when they are examining
I
you?
think that's the word he left out. But he immediately ordered a biopsy through that wonderful procedure. And then when he got the results, he immediately put me on ADT plus Lupron plus abiraterone. I've been on it for 5.5 years, and that's all I've done. I mean, I have my metastases are in my bones, and there's 5 of them that they found right away. and one of them is my entire. I can't remember what you call that bone. The in the pelvis, the big blade that goes on your hip. That's.
Ilium?
I think that's what it is. Yeah, it's fully involved.
Yep.
And the socket area is also fully involved.
Yep.
Then I have one on the spine. I have one on my the sit bone, whatever you call that one, the one you
Ischium.
and somewhere else too.
How's the PSA at the beginning, and how is it now?
PSA in the beginning wasn't horrible. It was 17. And now it went down to undetectable for a while. It's just slowly going up. I mean, it's still so low. It's 0.039 now. And it's taken about a year to go from, basically undetectable up to that. So my oncologist isn't particularly concerned. But we're going to see what I had. Actually, a blood test, a genetic blood test, but they also threw in all the regular blood tests too last week, and for some reason I'm still waiting the PSA result. Usually I get them the same day or the next morning, but this is a different lab. So they said
you had a good run, a good response to hormone therapy, didn't you?
Oh yeah, I've had a good response for sure. But in my case, 5 years is about where it starts to go south on you, because of the amount of metastases.
Yeah.
But we'll see over the next couple blood tests and see what's going on. I just actually got a referral because I'm really tired of taking these drugs. I got a referral to a urologist for an orchiectomy. Talked to him about an orchiectomy, and I don't know if anybody else has gone through that, but if they had, I'd love to get some comments on that.
Okay.
And, because I don't know if it's the lack of testosterone that's causing my brain to go off the deep end, or if it's the drugs, the Lupron.
I'm afraid to put in my vote on that because I think it's probably the lack of testosterone, and the orchiectomy might have the same side effects. But let's get the experience of somebody that's been through it, which I haven't. Did you get any imaging yet? CAT scans?
Hang on a second. I got some call coming through.
Oh.
I don't know what's going on here.
Did you get any
scans?
Lose me?
Me?
No, I'm still here.
No, we hear you. We hear you just fine.
I
don't think
I have nothing.
Oh, okay.
I don't know how to get back.
So you can't hear us, right?
I can hear you, but I can't see you.
Oh.
Well, we can hear you.
We can hear you and see you. Maybe we could continue for a while until you're up and running again.
Okay, I'm getting you back. No, my phone rang and everything went away. I'm sorry. Go ahead.
Did you have any scans?
I only had X-ray to begin with. That's all I've had, because it just showed, it showed everything.
So all those bone metastases were just on regular X-rays, right?
Yeah, that's correct.
Not even you didn't need bone scans or PET scans or any of that stuff. Just didn't need it, probably.
Just didn't need it. Yeah.
Who's your oncologist?
His name is Dr. Daniel Kalaf. I'm from Vancouver, BC, and he's in the BC Cancer Agency. And I'm not particularly happy with him. I see him every 3 months, and 6 months ago I asked him for 3 things, and he didn't do any of them. And then so 3 months ago I said, "Why didn't you do these 3 things?" And he goes, "Oh, I forgot." And so I said, "Okay, I need you to do these things." Well, he's done 2 of them so far.
What's his last name again, Greg?
Kalaf, Kahlaf.
K-A. HLA.
We've got
Okay.
some Vancouver people. I don't know if there's any here today.
So yeah, in the interest of time, and I'm sorry, it's just it's getting late, and I know we have to get to other people. I think there are a couple of key issues here, and other people may have opinions. I personally don't see the sense in doing an orchiectomy if the drugs are getting to you, if the administration of the drugs are getting to you that much, then there are alternative ways to administer the drug. Unfortunately, I recognize that Orgovyx may not be available in Canada, but that is a pill form of taking the drug.
Well,
There's not.
that's one of the things I asked my oncologist about, which I have not heard about. And I asked him for the
Okay.
second time. He said it's
So,
available, but if I'm already taking abiraterone and it's working, then it probably wouldn't be approved. But he
okay,
said
but
put in a
Scott, hold on a minute. Let us do the talking, and then you can take it back to him. Normally it'd be fine, but it's just I'm really conscious of time here. The Orgovyx is a pill form. The Orgovyx is not going to make any difference on how the abiraterone works versus Orgovyx or Lupron or Firmagon or any of the others. It's just an issue around how it's administered. Now, you can also, if you're getting it, if it's bothering you, getting it in your hip, you can get it in your gut. If it's bothering you getting in your gut, you can get it in your arm. There are a number of different places where it can be administered, depending on the type of drug. The easiest would be to go to the Orgovyx if you could get it. That's number one. The second thing is, having been on therapy for 5 years, there's a really good reason to talk about taking a drug holiday. And that would suit you very well because you would come off the drugs for a while. And we don't believe that it is inferior. It's non-inferior to take a holiday. That's what we've seen. Len, are you with us? Yes.
Yes.
Do you want to just give Greg a quick update on your experience with hormone therapy and with intermittent hormone therapy and taking a drug holiday? Because to me, that's what is being cried out for here. And the other reason why is because we've seen, and it's anecdotal, but we've seen too often that when men stay on a single secondary agent like abiraterone for too long, when the cancer eventually turns, which unfortunately it will, although in your case it might take a lot longer than 5 years. Don't count on that. But we can't find anything else to treat it with. So it's sometimes smart to come off it, to try a different drug, or to come off it, go back on the same drug, which is what Dennis Correa, I don't think he's on today, has done. But we want to keep the cancer off guard. We want to keep surprising the cancer. And when you've been on the same drug for 5 years, the cancer's figuring out how to work around that and everything else. Go ahead, Len.
So, Greg, you've been on Abby for 5 years, is that right?
5.5. Yep.
Okay, and you're undetectable.
No.
No,
Yes.
0.39.
0.039.
0.039.
Oh,
Well, I went on drug holiday when my PSA was at about that level, and I'm 21 months into my drug holiday right now. It's up to 0.2, and I'll be getting a PSMA PET scan soon, but took quite a while to get there. So, that's a discussion you could have with your doctor. You
How's
tell him you'd like to.
How is your metastases? What do you? What do you have?
I had 5 bone metastases 4 years
Okay.
ago. I went on Lupron and Nubeqa or darolutamide, but then I stopped when it became undetectable, and well, I went down to like half dose, and it became detectable. I think it was 0.02, and then I went on a break, and I've been on ever since. So 21 months. So certainly it's an option. Numerous clinical trials have shown that continuous ADT versus intermittent ADT, it's pretty much a wash. They're non-inferior. One is non-inferior to the other. So the only difference would be your quality of life will improve, hopefully. It actually doesn't happen for everybody, but it certainly did for me. So you're worried about your cognition, that certainly will improve, and your fatigue should lessen. Give yourself a chance to build back your muscle and bone strength. It's a lot of positives to being on drug holiday.
Yeah, one of the problems is that because I've been on it for so long, my testosterone may not come back. So all of those things may not happen.
What was your testosterone like before you started?
I didn't get a test before I started.
Okay.
But now it's, undetectable.
How old are you?
I'm 69.
How old are you?
69.
Well, you're not that old. It should come back. It may very well come back.
Yeah.
Only one way to find out.
Yeah, and Rick, I know most of those points that you were saying, and I did talk to my oncologist about possibly switching to enzalutamide because the evidence is also showing that if you're on enzalutamide before you go on chemo, which I'll have to go on sooner or later probably, that once you go back on the enzalutamide after the chemo, it becomes more effective. So I did talk to him about that.
Yeah, I mean that can be true of the abiraterone too, but I think the best thing for you. When was the last time you had a bone scan?
Oh, I haven't had a bone scan. I've had only a bone density.
Okay, well, I think you need a bone scan. I mean, again, that should be every year. They should be watching when you're metastatic. They should be watching. So the first thing to do is to ask for a bone scan. Let's see where the metastasis is right now. We have no idea. So we need a bone scan. We need to see what the situation is with probably just a simple technetium 99 and even a CT scan to see where you are. And then if it were me, I would definitely be considering a holiday.
Mm-hmm, mm-hmm. I did discuss that with him, and he wasn't really up, for that. But I am going to discuss it again.
I mean, we have so many. I saw Dennis Correa was on, but he's left now. But Dennis was on. Dennis was on for 4 or 5 years. He got off. He was off for about a year, and then it started to go back up again. You will. The thing to do is to agree with your doc when you're going to resume treatment.
Right.
And then when you hit that number, and you haven't even been through chemo yet. I mean, you have a long, you have, I don't want to say a long life, but you have long expectations. I mean, you can be around for a while, and I definitely wouldn't even think about an orchiectomy or even discuss it because it's not reversible. You can't do a drug holiday if you have an orchiectomy.
Yeah, I'll have to talk to him about that. And yeah, no, you're absolutely right, but yeah.
Greg, please note that Jim has put something in the chat if you can find that. And I'm going to see what Neil Sundstrom has to say and then move on. Neil?
Yeah, thanks. Rick specifically, or anyone here, John or Lynn, obviously Greg's in British Columbia. He's let me know he's not happy with his doctor, and so the question is, uh, how to move to a good doctor up there. And so, recommendations or introductions or anything to someone in British Columbia that can where he can move to, because again, his doctor I think has been quite adamant about not agreeing with him on a number of things, but and not getting him some of the things he needs. So if there's some way to reach out to or find qualified doctors in British Columbia, I think Greg could use that help.
Well, I mean, the go-to guy is Kim Chi at Vancouver Prostate Cancer Center. I think you mentioned you knew him.
Yes, and I asked for him to begin with, but I didn't get him.
Okay. And is this doctor you're seeing at the same place as Kim Chi?
No, he's at BC Cancer, and Kim
Okay.
Chi is at
So
the. No, actually, Kim
Vancouver Prostate.
Chi is at BC Cancer. Yeah, he is. Yeah, they're the same place.
I thought he was at Vancouver Prostate Center, but I may be wrong. But I would say I'll look it up right now. But if you're not, I would try again for Kim Chi and then see who he delegates you to, because I would trust whoever he delegates you to, because he's working with him. Let me have a very quick look as to.
Sorry about that.
It's okay. Rick, I'm gonna move on, and if you find any, just interrupt me,
absolutely.
okay?
Yeah.
I have 9 men and 29 minutes or something like that. So I'm gonna go in order of when you arrived. But if there's somebody whose situation is pressing, I would really like you to speak up because we don't want to let anybody go. And Terrell's not here, is he? Okay.
No.
He was left over from last time. So Todd Riki was the first person on my list. Todd, are you
Hold
still
on.
with us?
What? Just 1 second. Kim Chi is at Vancouver Prostate Center. So, and I'll put the thing. So my suggestion to you would be to call up, make an appointment at Vancouver Prostate Center if you're able to do that. Ask for Dr. Chi. If he can't see you, go to whoever it is. But here's I'm putting it in the chat window right now. But there you go, Greg and Neil.
We would very much like to see you have a consultation with an expert, given your situation. Todd, are you there?
I am here, and I'll go ahead and turn my camera on so that you can see that I'm a real person.
Hey, real person.
Thank you for the time. I appreciate that.
You're welcome.
So a thumbnail of what got me here. Found out that I was metastatic in April. Went on ADT with University of Chicago. So it's been almost 6 months, and I had lymph node. They thought there was something in one of the bones, but I had lymph node up in the abdomen, and obviously down in the pelvis. And so I just went back to University of Chicago and had scans Friday. Had a PSMA. What's the one that's PYL? Polarify scan, and it came back completely black. Nothing. So
what made you think you have metastases?
Well, I did have. I mean, it was in the scan. The PSMA that I had in April showed, it was lit up like Christmas. It was red.
That was a PSMA scan diagnosis, and now they're all dark.
And now it's all dark, which was amazing. However, what happened was there was a 142-minute time frame from the time that they injected to the time that they scanned. And from what I've read, normally with the radioactive material that they put in there, it's 60 minutes ideal, and 90 minutes is when it starts to.
Not with Pylarify.
Okay.
That is true. That's true with gallium-68. The half-life for gallium-68 is, I think, somewhere around 65 minutes. But the half-life for Pylarify is a lot longer. I want to say it's 180. I just heard this, so I should remember. But I can't remember. But I'll see if I can find it right now. But the half-life is a lot longer. It's definitely more than 142 minutes for the PYL.
Well, that's incredible, Rick, because if that's true, like I said, the scan shows that everything is gone. And that's pretty incredible. They said that there was the slightest trace of a red showing in the pelvis, but that it was almost not visible. So that's very encouraging what you're saying, Rick, because if that's true, then and I actually reached out to Pylarify, whatever it is, to the actual company that makes the product.
Yeah, Lantheus.
Yep, and I sent them a thing, and they got back to me right away, and they said they can't really give advice, but then they said we can hook you up with this group that can give some advice about the 142 minutes. But that's my issue right now, because if it's black and that's real, it's basically saying that I'm in remission.
That's an excellent question that you raised, and it looks like from what Rick said that it's a valid scan, and you probably could get another one in 6 months.
Yeah. So hold on a minute. So I have to remember where I heard this question was asked last week, and I was listening on the thing. What I'm finding right now is 108 minutes, but I don't think that's right. I am sure. So I'll do some more looking. I just Googled it right now, and what I find is Pylarify is radio label, cyclotron produced with a half-life of 109.8 minutes. But I have to look a little more. But I guess what I'm confused about is, I think I was wrong. I thought it was 3 hours. Oh no, wait a minute. Now I see another half-life of 3.47 hours. Medscape, Pylarify, half-life 3.747 hours. That's what I heard.
No, Pylarify uses F18, which has a half-life of 110 minutes.
I'm looking at something else here that says, that clearly says the half-life is 3.47 plus or minus 0.49. So I don't know. And that's what I heard in this presentation. So I don't know if it's 110 or if it's 180, Todd.
Shmulewicz should know, though, right?
Right.
Who should know?
Dr. Russell Shmulewicz.
Yes, Dr. S should definitely know. And I can't imagine they would give it to you if the half-life wasn't long enough.
So David,
that would be.
So David, I sent Dr. Russell, a note right away saying, hey, I'm concerned because I read that it was 60 minutes is like prime time, 90 minutes is when it starts to lose effectiveness, and I know that it was 142 minutes, and it makes me concerned because what if we're thinking that this black scan means I don't have cancer, but in fact it's because the test was wrong, because the product life in my body was dissipated. And he said, I think it was a good scan because of this and this, but we'll know more as we scan in the future. And it made me feel like, maybe he just wasn't fessing up to the realities of what it was. Because the other thing that happened, which was really shitty, was when I had my blood work done and my the urine, I read the cup that I was going to do the pee in, and it wasn't my friggin' name. This is at University of Chicago, Friday, and the nurse comes back and I said, "Look, I just looked at this thing, and the print is super small, but it was definitely not my name." And I said, "What's going on here? This isn't even my name." She says, "Oh, okay, let me take that." And no apologies, no explanation, and it just kind of freaked me out. It's like, what's going on with this hospital? I mean, 142 minutes between the time that I was injected with the radioactive material to the time that I was scanned, and the urine thing, and I just mind blowing, frankly.
Why did it take so long, Todd?
Well, it took a very long time before I got there to do the scan, and then they said that one of the machines or one of the computers was down, so it took another half an hour. So it would have been approximately 100. It would have been about 110 minutes if I would have gone in at the time that I was supposed to have. But then they said, "Oh, we've got to back up because there's a machine that's down. One of our machines is down, so we have to wait for a little longer." So that's when it became 142.
Okay, so here's the possible explanation. The elimination half-life is 3.47. It could be that the elimination half-life is not the same as the activity half-life, which is what Kurt is saying, and it could be that the activity half-life, the time in which it has to be administered, is 110 minutes. So I think if this was me, and we can send you references for the 110 minutes, I would present that 110 minutes to Dr. Shmulewitz and say to him, "Doc, I'm not happy with this. I want another scan."
Right.
And they need to justify it. And the Pylarify itself says that it is it's 110 minutes versus 68 minutes for the gallium scan.
So meaning
Did
110 minutes, at 110 minutes, it's no longer as effective as it could be, should be?
No, it means that
Well,
half of the radioactivity is gone at 110 minutes.
So does that mean at 142 minutes that it still might be okay?
Might. Did the salivary glands show up?
Okay, so he did mention. Let me just. He did mention. Let me go to the thing here, because he did mention something about here's why he thought it was a decent scan.
Salivary glands and the bladder.
Give me 1 second. I can sign in. I hate to take up more time because I know everybody's got stuff to do here, but I can find it pretty fast. Here it is, right here. What he said was. He said, when I said, I'm concerned about the time frame, he said, fair question. I don't think that is a concern. When I look at the images, the uptake in the salivary glands, normal. Liver and kidneys, where it is processed, is appropriate. Is that what you're asking, Dr. John?
Yeah. If the salivary glands were lighting up and there was normal physiologic background radiation in the liver, kidneys, and the bladder was lighting up as it was eliminating it, that means that if there's enough drug to light up those, there should be, enough radioactivity to light those up, there should be enough radioactivity to light up your metastases.
That's a really good point.
But nothing lit up.
Well, because there was nothing to show.
No, that's not true that nothing lit up. The normal uptake in the salivary glands did happen.
Right. So in Todd, what we're saying is this: the salivary glands express PSMA.
Got it. And that's the saliva, yeah.
Right. And that lit up. but nothing lit up down in the area where we might want to see metastasis in the pelvic area or in the bones or in the ribs close. Nothing showed up there.
Right.
So what Dr. John very smartly is saying, hey, and this is probably what Dr. Shmulewitz says, look, what showed up, what was supposed to light up, lit up, but nothing else lit up. So now we have reason to think you're okay. The stuff was good enough at 110 minutes or at 142 minutes, notwithstanding there was enough strength in it at 142 minutes because some stuff did show up.
Okay. So you wouldn't feel like I should do another test right away, wait for a while?
That's a tough one.
Yeah, we can't really say, but we can say that there's a good argument that it might have been a valid scan. And maybe the next one could be done at 3 or 4 months instead of 6 months.
Right. And in 1 hour.
Yeah. I mean, the fact is, it's poor show.
Yeah.
And you know, and if it were me, I would probably make a complaint because it's inexcusable. It's malpractice. They shouldn't have given it to you. They should have sent you home and called you back the next day.
Right.
And why should they do that? Because it creates patient anxiety, and that's something that you should point out to Dr. Shmulewitz, and he'll get it. He's saying, I don't want to trouble you to come back the next day because I think it was okay. But can he say, I'm sure it was okay? No, he can't.
No, and
but
he did.
Anyway, I think Bob McHugh says his was done at 76 minutes. Anybody else have anything to say on this one?
Yeah, let me just
the scan's supposed to give you, some confidence in something, and without it being in the time frame, you've lost your confidence.
That's
Jack, right. Quickly, and then I'm going to move on.
Jack, let me just read something very briefly. The distribution half-life is 0.17 plus or minus 0.04. The elimination half-life is 3.47 plus or minus 0.49 hours. So the distribution is, as you said, very long. You got 3.5 hours plus or minus, and the elimination half-life is very long. Distribution is relatively short. Takes very little time to distribute. Takes a long time to eliminate, and therefore it would take. He has more than enough time to see whatever he had to see.
Well, that's great news.
According to this, so that is good news from a macroscopic point of view.
Thank you.
Thank you for your time.
Okay, Todd, I'm going to go on if it's okay with you to Frank.
Thank you very much.
Okay, I'm going to try to make this as fast as I can. I did say 2 weeks ago that I got my genetic testing back, and it showed 5 somatic mutations. I talked with my doc about it, and he said he wants to wait until October the 10th, which gives me 5 weeks on abiraterone, which he put me on, abiraterone plus prednisone in place of darolutamide, and kept me on the first-line ADT of Orgovyx. I have questions to him that I'm going to discuss and give to him, and the question is the MRI-guided SBRT spot radiation that is available in Detroit, Michigan at the Henry Ford Cancer Center. And I want to ask him about, would it be feasible to use that, and how would I get a referral? The other quick question I have after I quickly finish is, has anybody gone through that, and how many treatments do you need to spot radiate 2 lung nodules? The second thing is, now because I have a BRCA2 mutation, the PARP inhibitor, the one that I looked up was Rubraca, which was in the Triniton 2 trial. And the main reason is that's the newest one that's been approved, but it also brings in a liquid a liquid blood test that is available with
Yeah,
with
let me stop you.
Mhm.
Don't worry about the blood test. It's recommended that you do it with the foundation medicine. What you did was the foundation medicine test, okay? And
Yes.
what was it, the liquid test that you did, or was it the solid tumor test? I can't remember.
It was a solid tumor test, not
Okay.
liquid.
Yeah, so it doesn't matter. So the fact that you have the solid tumor test is just as good. You don't have to do a blood test again. And it doesn't really matter, frankly, what group you who does the testing. We know that you have a somatic BRCA, and we also know from previous germline that it's not germline, but that doesn't matter. So let the doctor decide which PARP inhibitor he wants to prescribe. There's a choice of 3. You've got rucaparib, you've got olaparib, and you've got niraparib. And so whichever one he decides, you're fine. What you want is a PARP inhibitor. And the dosages are different because the strengths of each one is different. So the question is, 1, should you go through spot radiation at the same time? And 2, should you continue with the abiraterone whilst you're doing the PARP inhibitor? The PARP inhibitors are toxic. If you're not getting any benefit from the abiraterone, let Mortasavi call it. He may want to suspend it, he may not. He doesn't want to suspend it yet. That's number 1. Number 2, I wouldn't run around the globe just so that you can get the view ray to do the spot. You've done fine before. You haven't had an issue, thank God, when they've done spot radiation before. I mean, just get it where it is. It makes it easier on you. It's not like, unless he's saying that we've got a real issue in targeting where this is. So, for example, is one of these, where are the mutations? One on the lung, right?
Yes, one on the left lung, one in the right lung. The one on the left lung is the newest one that just was identified 6 months ago, but it's sitting right at the pleura at the far edge of the lung next to the heart.
Okay, so you have to, rather than asking him, can you go there? I would ask him, does he think it's necessary to go there? If he thinks it's necessary, he's going to send you there. Right? I mean, I don't know what equipment they're using. I don't know enough about spot radiation therapy to know whether the additional precision is required or it isn't. I don't think we should assume that the view ray is going to do better. Go ahead, John.
Plus, keep in mind that we're kind of expecting a good response from your PARP inhibitor. Isn't that fair to say? He's got a BRCA2 mutation. It's probably going to work, right? So is radiation even necessary? We don't know yet.
Yeah, I mean that's another good point. Try the PARP inhibitor and see if the PARP inhibitor eliminates it. The drugs can work. Look at Todd. So the drugs can work. So the question to Mortasavi is, how would you sequence it? Do you think we should be doing all this at the same time? Has he told you that you should be doing spot radiation and PARP inhibitor?
No, I'm bringing the question to him.
So the question to bring to him is, what treatments are on the table and how would you sequence them? And then you have the knowledge if you don't agree with him. then you can come back to him, Frank, and say, well, what about doing the view ray? What about doing the view ray at Henry Hudson, the MRI guided view ray at Henry Hudson, if you're not happy with the answer? And he'll say, could do, but I don't think it makes a difference based on his experience, because we don't know. You may say, what about doing, he may say, let's do the PARP inhibitor, and you'll say, well, what about the spot radiation? He may say, let's see what the result is. But we shouldn't doctor ourselves. We should have the knowledge, but we shouldn't doctor ourselves and say, okay, well, I want to do the PARP inhibitor and I want to do the spot radiation, because we don't know. What we do know is it's all pretty toxic. And so, doing abiraterone, a PARP inhibitor, and spot radiation all at the same time, that might be a big ask. But they're all on the table.
Mm-hmm. Okay, I appreciate the input.
It's a great question, and we could talk about it for a long time.
John.
But
John,
I will.
John, give me 1 second to tell him something about the view ray.
Oh, okay.
You may be able, Frank, to eliminate immediately the necessity of view ray if you go inside that tiny little tube and see if you're flexible enough to lift your arms for 2.5 hours above your ears and keep them that way. I couldn't do it. So as a result, I ended up with SBRT because I wanted view ray because I know all about it. It's terrific, but I couldn't. I'm too old. My shoulders have got too much damage from injuries. And if you're capable of lifting your arms and you can keep them like that way above your head for 2.5 hours, then optionally you could save view ray. Otherwise, forget about it.
What a good
It's very
point.
narrow and it's very difficult. For me, it was. But maybe you're very flexible. Maybe you're a yogi.
Okay, thank you.
I think we may have just lost Dr. John. So I can pick up, but I don't have a list of who else we have. We've got about another 20. Oh, he's back. Are you back, Dr. John?
Yeah, sorry, my internet disappeared for a second. I had to switch again. I had called David. Did you hear me, Dave?
No, I did not, but I hear you now, Dr. John.
Okay,
All right,
very good.
so in line with kind of what we've been talking about, I'm seriously considering a drug holiday. Quick history, for 2 years, I was on Lupron and the second line drug, and then got off of those drugs and been on lutamide, monodera for about 1.5 years. I'm ready to take a break. Can't handle the hot flashes anymore, and I'd like to get rid of this brain fog, and so I'm going to take a break. And I clearly heard what see, that's what happens with the brain fog. I clearly heard what we heard before, and just wanted to get anybody's input. And I can talk to, should I drop it in half first? I know I probably should talk to Shmulowitz, but drop it in half first and then do it, or talk to Shmulowitz and figure out how to taper.
Are you still non-detectable?
Still non-detectable.
Oh,
David, just take a drug holiday. I've been on drug holidays since April. It's fucking awesome. It's awesome. Now I'm about to start back up again because my PSA is back up again. But it was a really nice summer. It was really nice. You feel normal. You feel like you. Quality of life, baby. Quality of life is worthwhile.
Yeah, and Len, you feel the same way, right?
Absolutely. And the way I did it, David, was before I dropped Darrow completely, I cut the dose in half for probably about 3 months.
Yep.
And then I saw that the PSA wasn't moving. and so I dropped it completely.
Okay. And I
As far as the question of whether it's safe to do, you've had well over 2 years of ADT, and that's about the most I've seen recommended in the guidelines as far as putting the thing to sleep for a while. You
Right.
were a Gleason 9, weren't you?
No, I was only a Gleason 7, 4+3.
Oh, I really think I vote for it too.
And David
Okay,
knows what
4+3.
my vote is. I don't have to. I don't even have to speak up. He knows I'm going.
But I really should do it under the guise of Russell, Dr. Russell, right? I mean, I should
Oh
work with him
yeah,
and do that.
absolutely. Yeah,
I should
my
do it.
Darrow was stopped cold turkey, by the way.
Say that again about.
My Darrow was stopped cold turkey. I didn't taper off.
Okay. All right. All
So
right. Well,
Peter, we just heard from you, and you had something of your own to bring up. So
Oh,
now's the time.
it's a minor issue. We don't have time for it. It's fine. I'll do it next time. It's not a big deal. It's not a big
Okay.
deal. It's
But
really not.
Peter, when you went on your drug holiday, did you titrate or did you go off right away?
Just stop it. I was just on the Firmagon, the injections in the stomach, so it kind of titrated on its own.
Yeah.
Um,
Yeah.
but and it took, I would say, 3 months to feel normal. But I feel great right now. I really do. I feel great. I'm kind of I'm kind of bummed that I have to go back on medication. But it is what it is. But I kind of feel like you take your opportunities when you can get them.
And it doesn't mean you'll never get another chance either. Len had a couple of shots on
Absolutely
you.
right. Absolutely right. Absolutely. I'm expecting to go around. It is what it is. But I've told my doctor on multiple times I don't want to go scorched earth. I don't want to do that.
Yeah. Okay, Jeff with a G.
Yeah, so I'm sorry I don't have a camera. For some reason, it's not accepting it. I just want to bring this up to those people who are on things like Firmagon and Zytiga and other androgen deprivation treatments. One of the things that was brought up before the therapy was uh, osteoporosis developments. You're encouraged to take calcium and vitamin D and sometimes injections of bone builders like Prolia. I'm going to tell you an interesting situation and do with it as you like. But before I was ever diagnosed with prostate cancer, I had a bout of kidney stones. And I am an internist. So when I got out of the hospital, I did a 24-hour urine for calcium. And my 24-hour urine for calcium was way high. It was over 500. And I was not taking calcium or vitamin D supplements at the time. So that's a real number. I had a couple of conversations with an endocrinologist, and it turns out that there are men and women who have a genetic predisposition to losing calcium in the kidney. In the renal tubules, you cannot resorb the calcium. You lose it in your urine, and you go on and develop osteopenia and then osteoporosis. That's without these medications. So the question is, if you're told that you have to protect your bones, for me, I came up with a solution how to decrease the loss of calcium in my urine. I implemented it. It was relatively innocuous, and I cut my urinary calcium losses in half, which then means if you're going to go on these blockers and worry about osteoporosis, at least you're not losing all the calcium you're taking in your urine. You can resorb it or block secretion in the tubules, and have enough calcium in your blood to build your bones, especially if you get bone building drugs, Fosamax and Prolia. So I just want to bring that up because it's not that rare, and you're wasting time taking all these supplements if you can't resorb your calcium.
Jeff, how did you outsmart your kidneys? Did you change the pH of your urine?
Well, I did that for the stones, but I put myself on hydrochlorothiazide,
Oh.
a diuretic, which decreases tubular secretion of calcium in the kidneys. And I have high blood pressure, so the hydrochlorothiazide was good for my blood pressure also.
So I'm laughing, Dr. Jeff, because I'm one of those people. I have I leach calcium, and when at 56 I found I was osteoporotic, despite running 3,000 miles a year. I mean, I was so surprised, and I'm sure that is the explanation. I was put on HCl, and I was allergic to it. I couldn't tolerate it. So I came off of it, and I just stuck with amlodipine, which is what I've been on ever since. But that's really interesting that hydrochlorothiazide could have been a solution to me retaining calcium.
Right.
I mean,
if you're losing it in your renal tubules, you're not resorbing it. It is a solution. And if you're allergic to hydrochlorothiazide, you could try chlorthalidone diuretic.
So, well, they gave me the hydrochlorothiazide as a blood pressure med, and that's
Right.
when I found out that it wasn't good. I always have marginally high calcium in my serum. Calcium is always marginally high. I've never looked at my urine calcium. I suppose I should at this point, but and in my case, it's also a family issue. There are other people in the family who have exactly the same issue.
You should also look at your parathormone levels. Make sure you
Right.
don't have hyperparathyroidism.
I didn't last time, but my sister definitely does.
And there's a thing called familial hypercalcemic hypocalciuria that runs in families too.
Yeah, we have it. We have it. I mean, my dad must have lost 5 inches in height. I probably have lost a good 3 inches in height. My sister has chronic kidney stones, and you know there were calcium deposits in my prostate. But it's very enlightening. Thank you, Dr. Jeff, for the information.
One other small point. I do have osteoporosis. I took a DEXA scan, and I have had back pain, for lower back pain, as many men do, for years. It's very interesting. Since I've gone on the hydrochlorothiazide, which is now probably 4 months, the back pain started to decrease. And since the Prolia, which is about a month ago or a few weeks ago, my back pain is gone. So if this is placebo, I'll take it. But I just wonder if with more calcium in our blood available to our bones, if we're not going to build back our bones and protect them from fractures, because the last thing anybody needs on these drugs is to fracture a hip, especially if there's metastasis in the bones, which weakens the bones by the Mets. You don't want to have a broken hip, broken wrist.
This kind of case study deserves a letter to the editor in an endocrinology journal. I want to go now to the other Jeff, Geoffrey.
Hi. Okay, quickly, I've been trying to get approval for Orgovyx and darolutamide. So I just received a letter from Bayer saying they denied my request for the darolutamide on financial terms, and it's been denied by Medicare as well. So now what do I do? I have to go back on enzalutamide, I guess, is my only option, or is there, can anyone suggest something else?
I'm very disappointed in Bayer. I know
I
that
am very,
when
well,
I
I mean,
was
you have to
on,
be like a multimillionaire to afford this
yeah,
thing.
I was on the same program and I had a pretty decent income and they approved it anyway. So I'm really disappointed that they did that.
Yeah. Is there some, I don't know, they say I can appeal their denial, but they'll want lots of financial records to back up my appeal or something. I don't think
So,
Appeal it
Jeff,
anyway.
I'm having trouble hearing you here.
Ah.
I might be the only one. You said that Bayer denied you they denied you on the basis of your financial wherewithal. Is that
Yeah,
right?
I'm not poor enough. Yes.
Okay. So so you applied to them, and you're on Medicare, right?
Yeah. And
And so,
Medicare took me down too.
with Medicare's approved the darolutamide.
No, it didn't because I'm not on chemotherapy. That, they say that's what it was approved with is carbotaxol or something. So with
Okay, so let's step back one. So Dr. Agarwal recommended darolutamide, and Medicare turned it down. Is that right?
Right.
Your carrier turned it down.
Right.
So now what you've got to do is go back to Dr. Agarwal and say, "Can you help me get it?"
Yes,
Right?
which I did.
And what did he say?
Well, then we went through the PAP, application, patient assistance
Right,
program.
and you didn't get it, but the PAP
Right.
application. So now he's got to go back to your payer and try and get it. There are doctors who get it. We know doctors who get darolutamide for their patients who are not getting chemo.
Okay. So
We've
we
got
could.
we've got several people on this group tonight who have that. I'm talking quickly because we've got about 3 minutes left. Okay.
Sure.
So you've got to go back to Agarwal and say, I'm not going to get it through the financial program. I need to get it through Medicare. Then it's going to cost you. It's only going to cost you until you get through the donut hole. So then you have to make the decision. Is it worth paying for the darolutamide, or do I want to go back on the enzalutamide?
Well, I think it would be because I didn't like enzalutamide, what it did to I didn't like, from what I read about it, I don't want to do that again if I don't have
Okay,
to.
so if you can get your payer to approve it, which the doctor is going to have to get involved in to do, and he can make the argument, well, he didn't do well on enzalutamide, and the payer says, okay, we'll approve it, then you're going to have to pay for it according to whatever your payment plan is. So you won't get, which a lot of the guys are dealing with here. And then once you get through that donut hole and you've paid whatever, the premiums are, it'll go down to next to nothing. But that donut hole might be at around $4,000, $5,000, $6,000 to get through it, which you might get through very quickly because these drugs are expensive.
Right. Yeah, less, probably 2 weeks worth or something. Yeah. So.
That's right. It's crazy, but I think that's what you've got to do. But we've got other guys in here who are getting it that way.
Yeah. Okay. So I will go talk to him about that and
Go back to Dr. Rahul and say, I really want this, and my guys have said I have to get chemo first. My payer, can you justify it? Can you justify it without my getting chemo first?
yeah. All right. Well, maybe, I've documented that, I had depression and brain fog and things last time. I had flutamide.
Right, but he knows that. I'm sorry to rush you through, but we've just got. Is there anybody else, Dr. John?
I still have two left. Jeff Markey and Mark V.
Okay.
I don't see Mark V on here anymore. Oh, there he is. He's still here. Jeff and Mark.
I can wait till next week, John.
Okay, who was that? Who said wait till next week?
Mark Valens can wait. I'll wait till next week. Mark Valens.
Okay, I got you for next week, Mark Valens, and I got Gary Z as a new next week. And who else do we still?
Peter Hake also said I'll bring my issue up next week, I think.
And Peter Hake for next week. And who else do we still have?
Jeff Markey.
Me.
Yes.
Can I do a quick one? Or no time?
It's got to be really quick because
right.
we've got the MS coming in.
The PCRI conference. The second day of PCRI had Eugene Kwan on. He did a fully, just everything about how advanced prostate cancer is treated, from the minimalist person to the most extreme person. He's had people in from hospice who has told them they had no more treatments. He's got some of them living 15 years still. He's got some incredible
let
information.
Me just say, be my guest. You go to him then. You're very welcome.
You should listen to what he had to say about
we've listened to him too many times, Jeff Marchie.
It's an incredible amount of information.
We've been listening to him longer than you've had prostate cancer. And the issue is that when it comes to doing some of these new things, you can't get it done there. He's not, first of all, he's a urologist. Excuse me, I think Les is off because I don't want to upset Les, but he's a urologist. He's not a medical oncologist. On that basis, we wouldn't refer anybody to him. If we do refer people to him, he doesn't use the most up-to-date treatments. It took him forever to accept PSMA. He was going back to his C11
I wasn't talking about referral. I was talking about the information you can get on how to treat all different levels of prostate cancer. And he really goes into detail about which would work with your own doctor, not just him. But that's, the reason I came on was to mention that I've been on darolutamide a month and a half, and my PSA went down from 1 to 0.3 and then 0.1 in the latest test. Also,
so you went from 1.0 to 0.3 to 0.1, all on darolutamide, right?
Right. Well, but darolutamide was.
And how much is it costing you?
Well, the first month would have been $5,000, but I got Orgorvix first, and that I'm paying $12 right now.
Okay. And how did you get around the $5,000?
Well, you pay the first month. You pay it one time. You pay the full amount. And the thing is,
so Jeff, you paid the $5,000. Is that right?
No, I actually paid about $3,000 for Orgorvix, and then I paid $250 for darolutamide, and then the next time it was $12.
Okay, so you paid whatever that amount is that you've got to pay.
Well, it's $7,400, but the thing is, the $7,400 includes what your other people paid as well as what you paid. So you very quickly reach the maximum, and then it's $12.
What do you mean what other people paid?
Because what you pay is not the only thing that adds up to $7,400. It's also what your provider pays. So it's a combination of what you paid plus what your provider paid, which gets you up to the $7,400 limit. And
okay, so there you go. So there you go, Jeff D.
Yeah.
That you just need to find out how much of what in your policy, how much is your share of what it is. In Jeff's case, Jeff Marchie's case, it was around $3,000, $3,500. That's what you got to check. But but you've also got to get a doctor to prescribe it. So, and
Heartstark did.
Okay,
Also, I'm just going to mention.
wait, guys. I got to wind it up because there's another group coming in.
Oh, okay.
I'm sorry, Jeff. But thank you
It's
for
okay.
that comment
It's
for the
okay.
other Jeff. I also, in the last 2 seconds, just checking, Jeff G wrote some notes in the chat about hot flashes. And good night, everybody. I'm sorry it was a rush, and we'll see you next week. Okay.
Thank
Thank you.
you.
Thank you for
Good night.
coming and welcome you new guys. I hope we see you again.
Good night.